Hello, everybody. Thanks for joining my webinar. My presentation today is about the 7 things you need to know about feeding an infant with a craniofacial difference. My name is Erika. I'm a speech pathologist at Children's Hospital at OU Medical Center, and I'm a part of the Cleft and Craniofacial team there. I have no financial disclosures. The objectives are that the participant will be able to identify what issues may make oral feeding in an infant with a craniofacial issue difficult, discuss how bottle availability and cost can impact an infant's nutrition, and to discuss why a discharge plan should be the part of an infant's feeding assessment. Number 1 of the 7 things that you should know before you feed an infant with a craniofacial difference. What is the nature of the craniofacial issue? And I thought I'd start out by explaining exactly what a craniofacial anomaly is. In simple terms, it's a birth defect that affects the face or the head or the head. It may be idiopathic or genetic, and it could also be a traumatic injury as well. In the population that we're talking about today, we're going to be focusing on idiopathic and genetic causes of a craniofacial anomaly. And just to remind you, not all craniofacial anomalies impact feeding. So when I approach an infant, I want to know what is the nature of the craniofacial issue. Most commonly, it's the cleft lip and palate, but there may be more than what meets the eye. So we'll start off with the cleft lip. There can be an isolated cleft lip like the infant that's shown here. She has a unilateral left incomplete cleft lip. And really, a craniofacial issue like this doesn't generally cause any feeding issues. These infants can breastfeed. These infants can eat from any bottle off the shelf. There's usually not an issue with feeding. However, sometimes there's gum line involvement, even with an incomplete unilateral cleft, just like this one. If the gum line is clefted, that's where things get dicey, and we really need to assess whether or not the infant is able to eat efficiently from the breast or from just your off-the-shelf bottle. That will make a big difference on how to approach the feeding with that infant. If the gum line is clefted, chances are they will need a special bottle in order to be able to eat effectively. This is an infant with a bilateral complete cleft lip and palate. You can see his prolabium here, very exposed and very prominent. This infant has a wide cleft palate, and he definitely would need some help with feeding. So he would need the services of a feeding specialist in order to be able to grow and gain weight. When I look at an infant, I'm looking at the size of the cleft, if that vomer is very visible, and if the palatal shelves are I'm looking at the palatal shelves to see if the palatal shelves are wide or if there are no palatal shelves at all. The wider the gap, the harder it's going to be for that infant to eat. Not impossible, it just makes things a little bit more difficult. Pierre band sequence is another anomaly that I see a lot in my hospital. And it always stuns me how little is known among the other healthcare workers that I work with when we see an infant with Pierre band. It is critical to diagnose Pierre band quickly due to the issues with the airway. These infants have a recessed chin, glossitosis, which cause them to have difficulty breathing and maintaining their airway. If they are in supine position, they could have difficulty breathing. And what I usually see is the first 2 or 3 days, they do okay, and then they just go downhill and they have much more difficulty eating, much more difficulty breathing. I always like to remind the people that I work with that it is a sequence, it is not a syndrome, and it may or may not exist in the setting of a syndrome, most commonly sticklers, but there is no genetic test to diagnose just Pierre band sequence. It really is just a constellation of features, including a U-shaped cleft palate, the retronaphia, and the glossitosis. The tongue on children with Pierre are very recessed. They stick straight up in the air inside the mouth. And feeding is difficult with these kids because it's hard to get that tongue down. But airway patency is the key component for this population. These infants tend to do better if they are positioned all the time in prone position. They sleep better, they're more comfortable, and they can require a little less intervention. They also do better when feeding in side-lying position or as prone as possible, and still be able to bottle feed that infant to get that tongue up and out of the airway. This is the difference between a U-shaped cleft palate and a V-shaped cleft palate. It usually is a pretty prominent U shape. There's usually no denying it. These children have obstructed breathing due to glossitosis, and they must be kept side-lying or prone to help the tongue from occluding the airway. But if you can get them sucking, they breathe more comfortably. So if I'm feeding this infant or I'm removing them from the bed, if I can put my finger in their mouth and get them sucking on my finger, they handle that transition so much better, because just the natural movement of sucking, where it pulls the tongue forward and towards the opening of the mouth, pulls the tongue up and out of the airway, and they tend to breathe a little bit more comfortably. These children, when they cry, that tongue gets sucked back and they end up obstructing their airway with their tongue, and the more they try to breathe, the less they can breathe. Even though that these infants have a small jaw, a smaller nipple is not what these babies need. I see oftentimes a mini-sized Haberman at the bedside with these kids, which the mini Haberman has little chance, depending on the degree of the Pierre sequence. Mini Haberman has little chance of even making any sort of connection with the tongue. Just because that jaw is small does not mean that child needs a smaller nipple. This population, in my experience, has a higher probability of losing fluid through the nose. So as they continue to eat, they tend to lose fluid through the nose. So upright positioning tends to work a little bit better with these infants as far as fluid through the nose. And upright positioning, I try to position them as, again, just as forward facing as possible, or once I get the nipple in the mouth, then I can put them in side lying, because that tongue is going to be up and out of the airway if they are sucking. This is an intervention that we can use with a child with Pierre sequence. This is jaw distraction, and this is something that we use in our hospital quite often. It usually makes an improvement with the breathing and the feeding immediately after surgery. The distractors are kept on they distract for about 6 weeks, and then keep the distractors on for a couple of months, and then remove the distractors. And we have effectively grown the infant in airway. These infants, despite the way that they appear, do very well with feeding. They do very well with sleeping. They are, I think, sometimes a little scary for parents, but once parents get used to that device and they see the benefit, they're definitely on board and have no trouble handling and feeding their babies. This is another disorder that I feel like I'm seeing more and more in my hospital. Holoprocensephaly, which is an abnormal development of the brain, where the brain does not separate into two different lobes. They have distinct facial features, and oftentimes they have much bigger fish to fry than oral feeding. They're usually dealing with things like diabetes insipidus, seizures that they're trying to get under control. Here's a picture of a couple of children with holoprocensephaly, which also appears in concert with trisomy 13. Not always, but it's always something that should be ruled out. They have a distinct look to their eyes. Both of these children have a distinct look to their eyes. The little girl on the left has that cleft is very characteristic of a child with holoprocensephaly, and whenever I see a cleft that looks like this, that's the first thing that I'm thinking of. That nose didn't quite rise up the way that it should. The lip is a central cleft rather than a left or a right. It's very difficult to feed these children because just the feeding development, the development associated with feeding is a little behind, and not to mention the way that their structures are. There is no separation between either of those nostrils. It's really just one big opening. Another really common one is 22q11 deletion syndrome, or discharge. It usually does not include a cleft palate, but there may be a submucous cleft palate. Regardless, the velum doesn't move the way that it should in most of these cases. And oftentimes these kids are poor PO feeders. We will bring them down for a modified barium swallow study. I will see that the contrast penetrates the nasal airway and ask immediately that those kids be screened for discharge. That's a common indicator for discharge syndrome, is escape of the fluid through the nasal airway. These kids also tend to have a bulbous nose, a wide nasal bridge, just like the infant pictured. They have very long fingers and toes. As they get older, their hand strength is lax. So if you go to shake their hand really just slips out of your hand, and they tend to be hypotonic. This is another one that is pretty rare, but still worth mentioning. This child has a Tessier 7 cleft, which can affect both sides of the lip. Tessier clefts can appear all over the face in certain patterns. This particular child is clefted on the right side. The left side is intact. This also would be a hemifacial microsomia, where one side of the face does not develop as the right side of the face did. This child had improved feeding in a left side down position in order to minimize the fluid loss out of that cleft. It's also possible that taping may have improved oral feeding. The problem with that is that we would probably have to take off, place and take off tape with every feeding, because the tape would get pretty messy if we were to feed this child right side down or even upright. He may have been able to eat semi-reclined, but left side down works the best for him. Here's another picture of him just on that side, so you can see the degree of that cleft. He was repaired, and he otherwise was a pretty typical child. This is an example of craniosynostosis, and this is a pretty severe example of craniosynostosis. But this child had a condition called Behr-Stevenson syndrome. He had a mid-face hypoplasia, which means that the face, the middle of the face did not grow as the rest of the face did. He had a severe airway obstruction. You can see there that he does have a trach, and he is connected to a ventilator. We did try to feed this infant orally. He is not able to breathe through his nose. There's no, there was such little space between his nasal airway and his oropharynx that he was not able to breathe out of his nose. So he was not able to, this was prior to the trach. So he was really not a candidate for oral feeding. He had limited oral mobility as well. His tongue is protruding, and he was not able to move his mouth as we needed him to do in order to be a competent feeder. Here's a picture of him from the side. He did have surgery on his, he did have cranial surgery to help remodel that and remove some of the pressure. From this side view, you can see, you can't even see his nose. It's so, his mid-face is so hypoplastic. So number 2, how do you determine candidacy for oral feeding? Number 1, airway patency. Can the child breathe? If the child cannot breathe, the child cannot eat. Number 2, drive of the infant to eat. If the infant does not have drive to eat, Why doesn't the infant have drive to eat, and will it improve? Is this a premature infant who has no drive? Is this a neurological issue that the infant has no drive? Do they have a strong drive to eat, but they're having trouble breathing? What is the drive of the infant to eat? Are they syndromic, and what are the characteristics? Is the disease or syndrome that they have progressive, and are there any heart issues? Infants with heart issues are characteristically a little bit more difficult to feed depending on the severity, because if their heart is not efficient, then they can't circulate oxygenated blood through their body, and they tend to get worn out very quickly. If there is a drive to suck, we can usually figure out a way to help the infant achieve successful oral feeding, whether that's partial or full. Another thing to consider is how many surgeries will an infant have to undergo, and will they be able to maintain their oral nutrition? Will they be able to maintain their nutrition via oral means? So airway patency. How patent is the airway? Do they have Pierre band sequence? We know that that those children often have an upper airway obstruction by way of their tongue. So if their airway is not patent, then they will have difficulty feeding, and that's usually if we can help the child breathe, we can help the child eat. Crouzon and Apert syndrome also present unique situations, because they also have a mid-face hypoplasia, or they can also have breathing issues and cleft palate as well. It really doesn't matter what the craniofacial diagnosis is. We have to ferret out those problems and then deal with those problems from there. Does the infant have a drive for oral feeding? Do we have a drive to suck? And if not, why? Are there any comorbidities with that infant? Do they have a respiratory comorbidity in their past? Were they preterm? Were there any neurological issues with that would impact their drive for oral feeding? And if the infant has a syndrome, what is the syndrome, and what are the characteristics of the syndrome? These can all be predictors of success. And I will say that while it's good to have a roadmap, I think all of these children should be evaluated on their skills alone, and not just on the label that they've been given. I've had plenty of kids who there was no way that they should be able to do it, and they were able to maintain oral feeding, and some kids who really should have been able to do it that were not able to maintain oral feeding. So it's always important to fully evaluate these children and to help them achieve the most that they can achieve. I wanted to include this slide about breastfeeding. Breastfeeding is nearly impossible with an infant that has a cleft palate. Oftentimes, I have seen infants that have been admitted to our hospital or that come to our clinic just a week or two after birth, and the mom has been trying to breastfeed the infant because they were told that they would be able to do that without any problem. And in my experience, I've been with the Cleft team that I'm on, I've been with for 10 years. I have yet to meet a parent, a child who's been able to maintain oral nutrition fully by breastfeeding alone. In the beginning, if mom has a lot of supply, they can make it happen. But as that demand for more milk occurs, they are not able to keep up. Oftentimes, these kids show up in our clinic a week or 2 weeks after birth, and they are still not gaining weight. And if they cannot gain weight, then they will not be a candidate for surgery until they're starting to gain weight, and they will not heal well if they are not getting good oral nutrition. So what I hear is that the breast tissue can cover the cleft, and the infant should be able to breastfeed easily. And like I said, I have never seen that happen. The infant is just not able to build up the pressure necessary to express milk from the breast. They're able to chomp the nipple, they're able to lick the underside of the nipple, but they are not able to build up the pressure to actually extract and fully empty that breast. And it really is just an anatomical mismatch between mother and infant. Some mothers are are just absolutely relieved that someone told them this so that they can go to bottle feeding. Many of them really just want their infant to be fed rather than maintain that breastfeeding relationship. I always encourage them to try and encourage them to put them to breast, but oftentimes it is not a possibility. So if we are going to feed these infants with a bottle, what bottle options are there out there? And how easy are the bottle systems to obtain? I combined 3 and 4 in the interest of time. So I address both of these subjects on one slide. So there are so many options for feeding a newborn infant. There are fancy ones, new ones, the tried and true ones. Parents of infants with clefts don't have that luxury. I'll see infants born after they're a week or 2 old, born at rural hospitals or even not so rural hospitals. And they have been given parts and pieces of bottles, but never, but not the whole bottle. Sometimes they'll show up with whole bottles, the entire assembly, and they are using it correctly, but that's not the usual case. So my personal choice for feeding an infant with a cleft palate or some sort of craniofacial issue is the Dr. Brown's specialty feeding system. What I like about this bottle is that it's easy to use. If you can put together a Dr. Brown's bottle, and while there are a lot of pieces, it is not impossible. It is easy to use. You could pass a child around the room and anybody can feed the infant using this particular bottle. Brother or sister could feed using this bottle, grandma, grandpa, you name it. At a daycare, the daycare workers can feed using this bottle without a lot of instruction. It's affordable for families and for hospitals. I talk about the cost a little bit further down on this slide. It's $32. This is current information. $32 for a 5-pack on Amazon, which includes 4 extra valves. So you get 9 valves for $32 plus the 5 bottles. And then you can get a newborn feeding set, which includes the 5 bottles for $17. It doesn't include valves. So what I like about this is that they're easy to obtain. You can get them at your local big box store. You can get them on Amazon.com. What I hear parents, what they're most excited about is that this bottle has a lid. If they're coming off of a Haberman and using this Dr. Brown's bottle, they love that it has a lid. That's not something I ever thought of before, but I hear that all the time. It's a durable bottle. The nipples tend to last a little bit longer than some of the other ones when infants start to tease. And if they don't, then a parent can run to the store and get more nipples. It is not difficult to get these nipples and bottles. So if they have a handful of the valves, then these parents can just go to the store and get more bottles. They can get bigger bottles or smaller bottles or pink bottles or purple bottles. They can do all of that, which is not the case with some of the other products. There's no variability between feeders. So again, you could pass an infant around the room and the infant's going to get the same experience whether grandma is feeding or whether brother or sister is feeding or mom or dad. And Dr. Brown's also has a variety of flow rates available with the nipples. We could use an ultra premium or premium nipple, level 1, 2, 3, 4, or Y-cut nipple with this valve. So for ease of use, for being able to get it, and the cost, this one is my pick. Next on my list is a Pigeon Nipple. What I like about this nipple is that it is easy to use. It is pretty durable, and the valve that's pictured, you can fit that valve into other nipples if necessary. So you could use that inside of a hospital nipple if you wanted to. It's not my choice, but I have done it. There's no variability between feeders as long as everybody knows how to use the nipple. There's a notch, and you can kind of see it on this picture. And if the notch is lined up with the nose or the center of the forehead, then the infant should be able to eat. As long as the feeders involved know that, then the infant should have the same experience from feeder to feeder. However, there's only one flow rate. So the bottle that you get, the nipple that you get as an infant, and the nipple that you're using as you're getting ready to wean off of a bottle is the same. There's no variability in flow rate. They're difficult to obtain, and the nipple tends to collapse if not used with a vented bottle. So back in the day, I would use this nipple on a Dr. Brown's bottle, which is not possible anymore. There are some other, I think the Playtex bottle, it would work. But if it's not a vented bottle, then the infant can stuff that nipple flat and not be able to extract any liquids. This particular bottle is $9 for the nipple only and $23 for the nipple and bottle on Amazon. The Haberman feeder, also known as the Medela Special Needs feeder. This is my third choice. There are many pieces when you use a Haberman. It definitely looks different from other bottles, and there's no lid. I can't tell you how many parents have shown up with that bottle in their diaper bag, and they pull it out, and sometimes they'll have a Ziploc bag over the top, but no matter what, there's always lint or dog hair or dust or whatever's floating around in the environment sticks to this particular, the nipple of this bottle. It's not very easy to use. So there's usually a designated 1 or 2 people to feed this infant because the nipple, this particular bottle assembly is not easy to use. And parents often feel as if they are drowning their infant because the feeder does part of the work and the infant does part of the work. There is variability with the feeders. There are the 3 lines on the Haberman for a small, medium, and fast flow. That line has to be lined up with the baby's nose or middle of their forehead. Dad usually squeezes that soft teat a little bit harder than what mom does. So the infant feeds a little bit differently from mom than dad, or from if grandma or grandpa want to give it a try. This bottle's pretty intimidating and it's not as easy to use. This bottle is difficult to obtain, and this tends to be the go-to bottle for still a lot of hospitals. I don't like to use this bottle because I feel like if I give this bottle to a family to use, then I need to be able to give them resources in order to get this bottle. And to be honest, most of the families that I deal with cannot afford this bottle if they can even find where to get it. And I've had families tell me they've driven all over our state to try to find them at a hospital or a durable medical equipment place. They're about $30 a piece on Amazon. And infants tend to rip through these pretty quickly because the nipples wear out very quickly on these, especially as that infant starts to tease. I usually end up supplying these for parents if this is the bottle that is working best for their infant, but I try very hard to get them on one of the other systems that is a little bit easier to use and easier to obtain. The Mead Johnson feeder is one that we don't use anymore. It really takes infant effort out of the equation. I feel like it puts an infant more at risk of aspiration because really as you squeeze the soft bottle, the liquid is expelled from the nipple. It's not something that I recommend. It's very difficult to match the infant's pattern of bolus size and timing of the infant suck. So it just makes it difficult to match all of that. You can put any nipple on it. So this is the nipple that it comes with, but any nipple will fit that bottle. A case of 6 is $16, so it's fairly affordable, but it's only available through Mead Johnson's website. And not something that I mentioned before, but a lot of my families don't have a computer. They don't have access to Amazon. They don't have a credit card. They don't have those types of things. So being able to order something online is not a possibility for them, or they have to get somebody else to do it for them. It's just very difficult. So really being able to only order this through the Mead Johnson website or the Enfamil website, it's just not a realistic solution for them. And then this is something that every once in a while I will see come in from outside hospitals. This is what we call in our hospital a Brecht Feeder. There is an actual Brecht product, and I don't think that it's really available anymore, but it kind of works like this. This is what I call the desperate times call for desperate measures situation. It's really not realistic. It's really just a syringe with a slit tip on the end and a red rubber catheter. And it should be a very temporary, but not a long-term solution. And we will use it in our hospital occasionally post-palate surgery because it doesn't require any sucking. So in the past, when we had been using Haberman's, we would ask for the parents to start using a sippy cup with their infants, or at least introduce it to them. So post-surgery that we could maybe use that to help them drink. But now with the Dr. Brown's bottles and such a short nipple, a normal size nipple, it doesn't impact the stitches on the palate, so that they're still able to use the bottle that they're used to using. Here are a couple of other ways in order to feed an infant with a cleft palate or some sort of craniofacial issue. A supplemental nursing system, which is also not my favorite way to feed an infant, especially long term. So this is a system that you would tape a tube to the breast, and the infant would suckle from the breast, and the liquid would drip into the infant's mouth from that tube. Cup feeding, which also should not be a long-term solution where the infant can lap up milk from a small cup. I think that there's a lot of feeder variability with that method. Syringe feeding, which sometimes occurs right after the infant has been born, but again, is not a long-term solution, or cutting a hole on a regular nipple. And this is also something that I see from parents who have no idea what to do, and they come in to see for the first consultation at a week or 2 weeks, and they finally found something that they can cut a hole in that they're able to sustain their infant. So number 5, what is the sophistication level of the family? And this is important because this will also dictate some of the feeding recommendations that you'll give. So some of the things that I worry about when I'm working with a family, these are the things that go through my head. How will they be able to get more bottles to feed their baby? On my team, if I need to, I will provide all of the bottles that the family needs in order to sustain their baby. Most of the time, they like the freedom to be able to go buy them at the store themselves. The ones that I give them, it's what I have is what they get. So I can't give them the pink ones or the purple ones or the bigger bottles. They usually get 4-ounce bottles, and that's what I carry at the hospital. But if they're using Haberman's or Pigeon Nipples, then those I typically will supply for the families because they just don't have a way to get them. Can they afford the bottle? So can they afford any of the systems that I talked about are a little bit more expensive than your average bottle. So can the family afford it? And if not, how can we mitigate that? Do they have access? As I mentioned before, not everybody has access to big box stores or Amazon. I always like to help the family problem solve through this. And do they understand how to assemble the bottle? I always assemble that bottle in front of them, watch them feed the infant with those bottles, make sure that they understand how to do that, and then take it all apart and have them assemble it for me so that when they get home, that we all know that it's assembled correctly. And if it's one of the systems where it have to be positioned in the mouth a certain way, that they understand what to do. We do a lot of prenatal consults in my clinic, which can make or break the situation, and it can empower parents. So we do prenatal consults, and usually the information that we have is that the child will have a cleft lip, but we don't know if the child will have a cleft palate. So I always approach the situation as if they do, and give them something to feed their baby with, show them how to use it, encourage them to practice at home. So when they go to the hospital, if it's not at the hospital that I work at, that they have the ability to feed their baby without the need of somebody else showing them how to do it. Hospitals that are unfamiliar or maybe less familiar with clefts will scramble to figure out what gets the job done to get the infant out of the hospital. I would really prefer that if an infant born with a cleft lip and palate The challenge is usually feeding. So if we can arm the parents and show them how to feed an infant with a cleft lip and palate, that the baby could be born in their community, they can go home and then come see us a week or two later and make sure that everything is going okay. Oftentimes the nurses in the hospital where the baby is born, if they are not familiar with that, they scramble for information. They try to figure out what to do, and those are the infants that I see coming back with parts of bottles and not full bottles, not full pieces of bottles. Maybe just a teat from a Haberman bottle, or they've come without the valve from a Haberman bottle or something like that. So with a prenatal consult, you can educate and provide bottles so that feeding is as stress-free as possible, which is the way that it should be. So number 6, what is the situation for the infant after discharge? That's an important piece of the puzzle because you want to know what's going to go on after the child goes home. Are they going to go home with the parents? What is the sophistication level of the parents, and do they have support if they need it? Is a child going into foster care? In our hospital, if a child is put into foster care, the foster parents usually will show up on the day of discharge, feed the infant once or twice, and then leave. And so we want to make sure that we touch base with those foster parents. We tell them how to get an appointment with our clinic or make that for them, give them the bottles that they need so that they can get started, and go and take the baby home so that the baby can continue to grow and thrive. And that's true whether it's if they're going home with the grandparents, or going to be staying with grandparents throughout the day while parents are at work, if they'll be going to daycare. Are they going to have subsequent surgeries such as jaw distraction? Is that on the table? Any medical equipment like home oxygen, feeding tube? What is the situation that the infant is going home with? And finally, number 7 of the 7 things that you need to know in order to feed an infant with a cleft palate. Is the infant plugged into a cleft team? This is important because the cleft team should include a feeding expert. Good nutrition is really paramount for these children birth through 1 year of age. They cannot have their surgeries that are performed if they are not getting good nutrition and not gaining weight. Typically, the lip is repaired at about 2-3 months of age, and the palate is done around 9 months of age, just generally speaking, at least in my center. So making sure that these infants have good nutrition is key, whether it's for healing, brain growth and development, and the parents should not be spending all of their time trying to get it down their children. They should be able to feed their children in a reasonable amount of time, half an hour or so, and then be able to enjoy their infant and working on things that any infant would work on, whether it's tummy time or just interacting with the family. Sometimes the pediatrician is misinformed about cleft care. The pediatrician gets worried because of the cleft that they think the baby might choke. I'll get questions about the parents say that the pediatrician will not allow them to feed solids because the pediatrician is worried about the cleft. And these are all things that I like to go over with the parent. I always ask the parents if they have questions and talk to them about this. They often ask about speech, so I address those issues as well with them, but make sure to drive home that birth to 1 is the critical point, especially as far as nutrition is concerned. Good growth means a better repair. It means that there's more tissue to work with. It means that more growth has occurred, so that the outcomes will be better as far as appearance and function. Good nutrition means easier and better healing for that infant so that they can get back to life and get back to regular development with their families. And sometimes an alternative feeding method in order to achieve, that may mean an alternative feeding method in order to achieve good growth and nutrition. So a G tube, a gastronomy tube is not the end of the world with these kids. And it may be the key so that the parent can actually enjoy their child, especially if there's no drive to eat or if there are other issues going on with that child. So strong follow-up includes contact information from a feeding specialist. If these kids come to our NICU, or even if they're born in just our mother-baby unit in our birthing center, I always give them my card. I give them a sheet that regards our clinic and all the specialists that they'll work with, and encourage them to call me if they have any questions. I hate to hear that parents are trying to problem solve these things by themselves. I don't think that's fair, because I've done this a lot, like many of you, and I have a lot of things to try, a lot of tools in my toolbox, and these parents have none. I always give them written and/or verbal information on how to get the bottles that are recommended for the infant and that we've been using. So if those are the Dr. Brown's bottles, how to get those. If those are the Haberman bottles, how to get those. And when I recommend those are usually coming from me. It might be how to purchase those bottles and providing those supplies when needed. The end goal is a family who can feed their infant with as little stress as possible. I really, it's so disturbing to me when a family ends up in our clinic when the baby is 1 or 2 weeks of age, or sometimes a little bit older, and the parents look like they've been hit by a car. The infant is not thriving the way that they should, and it's because they didn't get good feeding in the center where they were born, and they have nobody that can help them, and they're trying to figure this out themselves. Parents should really be able to enjoy their infants and not spend every moment trying to get their infant to eat and to get it just down them. They don't get to enjoy their baby. Their baby is not having a good time. It's really pleasant for nobody involved. With proper support and thinking about the 7 things we talked about today, a parent should be able to feed their infant efficiently and spend time enjoying their infant rather than trying to feed them constantly to sustain weight. Not only are the surgical outcomes improved, but so are the developmental, psychosocial, and attachment outcomes. Babies are happier, families are happier, and that is certainly my goal. And just as a final, www.cleftline.org is a great resource. It has a lot of information about cleft lip and palate. It has great videos on how to feed an infant with a cleft palate using a lot of the bottles that I talked about today. So I will give that information to parents, especially ones that call me that I have not been able to see yet, that are having trouble feeding their infants that might have a cleft lip or palate. Thank you for attending my webinar, and I'll take questions.